left a very short time for the controls the group survival. So if we from 7 decrease to 5, let's suppose, so we did increase 2 months of the treatment in the induction. So from 5 improve to the 8. So the sample size could be totally different.
It can be different because after induction chemo, patients with PD are removed from the study before randomization. So it's a different story.
Yeah.
Patients with PD are removed. So
I think the overall survival is perspective is too short.
I believe it would likely underestimate the overall survival.
And also one more point, sorry to interrupt. Adjuvant patients who had previous exposure to CELOX. I mean, in colorectal cancer, it's a negative prognostic factor. So have you run some study, do you have any data about whether this particular factor is going to influence your maintenance difference? Because in Hong Kong, they all get, because we follow the Koreans, yes, we follow the classics. So there would be a lot of people who get that adjuvant. So you have to take that into account. Yes, it's a very small difference you're looking at, and then you on top of that, I think you're probably underpowered.
So I'm not aware of any data for that right now, but I would have to go back. But I would have one more question, because I have heard here now a couple of times that the overall survival assumption we have here with 10 months is maybe too short, at least for the active drug. For the control arm, I think was 7 months, if I remember right. Can you go back to the design slide, please? So what would be your assumption, based on your knowledge, for overall survival after randomization? So I've heard here 7 months, others believe it might be longer. So for an Asian study, let's say we talk about an Asian study.
Especially in Asian patients, it will be longer than 7 months after randomization. Even for, patients from other parts, especially United States and Western Europe, it may be longer than, slightly longer than 7 months. So,
would you go more for 9 months in Asia or for 10 months?
It will be safer, because with the time, patient survival is just very slowly prolonged.
Okay. Other opinions to that?
So I agree. 9 to 10 months would be more appropriate.
Maybe longer than 9 months, because you will the PD will just the poor prognosis is will remove so this the overall survival may be longer than 9 months. Yes, it's for this population is a very it's a good prognosis population.
Because that's an all-comer, no biomarker selective.
It's a very good point.
Yeah. We're still trying to. So actually the next question is really about the biomarker.
Hold on, before we come to the biomarkers. I heard you saying that in the literature tells 2 studies that were conducted against observation. So is that not possible here?
Conducted ipilimumab study, and most investigators from Western countries and East countries, especially from Japanese investigators, really wanted to continue some form of treatment. So,
okay, so it really didn't help.
But still, they wanted to continue oral fluoropyrimidine in their patients. It was so strong at the time.
Study was negative, so ipilimumab didn't work, right?
Well, the drug cannot work, or the design cannot work for the drug either way. It's negative.
as Professor Pang pointed out, the trial originally designed to compare with observation. Then it turned out to be 80 or 70% of patients received oral 5-FU as a maintenance therapy. So it became a trial to compare with EP versus chemotherapy. So it turned out to be negative. That's what happened to that trial.
So we had certain interactions with agencies. So we discussed with FDA, we discussed it with EMA, we discussed it also with the PMDA. And the feedback was mostly there should be something additional in the maintenance arm. You need to add some further therapy for these patients. Because in most cases, patients are getting therapy until progression. So this was feedback we received. Therefore, we had to include in one maintenance arm in the control somehow an active drug. Okay.
But from this clinical trial design, you means that patients can't get from the chemo. Maybe it's not sensitive to the immunotherapy. So I think maybe you will miss the lots of patients that will sensitive to the immunotherapy.
So, and actually, this is another question we can ask in the next one. So the first question is about biomarker. Right now, if we're going to go to first line or a switch maintenance setting, and also recently we know the positive OS data from Nivola third line, then we're trying to think over how to differentiate avelumab and maybe in the future TGF beta trap. So the question to the key opinion leaders, so in gastric cancer, do you have any idea there's a promising biomarker maybe we can further explore? For example, in-house data, we have very limited data in MSI high, and maybe someone will use PD-L1 expression, and maybe more complex like a tumor mutation burden, T-cell infiltration, lymphocyte, or others. So this is also an open question. Now,
I can comment on MSI high or EBV positive gastric cancer. So actually the frequency of MSI high in gastric cancer is 10% in almost all countries. But problem is these patients carry better prognosis. So if you see patient in metastatic or recurrent setting, it is much lower. Especially in Asian countries, it's less than 4%. So not easy to find such kind of patients. For EBV positive gastric cancer, same thing. Actually, at this time, we are running a trial to find EBV positive gastric cancer, multiple center, multiple countries. But during almost 4 years, we enrolled only 4 patients. So MSI high tumor seems to be, more responsible to immune checkpoint inhibitors, but frequency is very low. So probably not for big studies.
And Dr. Bond, I have a follow-up question. So in terms of tumor mutation burden versus MSI, so what's your opinion of the overlapping of these two subtypes?
Actually, measurement of tumor burden is being done in a very selected number of centers at this time. And another point is that actually there is a very good correlation between MSI high status and mutational overload and PD-L1 expression. So I think you can use PD-L1 expression at this time. And in the future, gene signature may be another, important player.
Any other comments?
Yes, I agree with Professor Bong. We also find the MSI high relationship with the PD-L1 high overexpression and mutation overburden.
I have a question to that. Is that dependent on first line versus second line setting? Is there a difference, this correlation of PD-L1 expression and MSI?
We can't find any correlation with the first line and the second line.
Okay, I'm asking that question because obviously up to now it's only pembrolizumab who have a PD-L1 selection, a patient-based patient selection, and no other checkpoint inhibitor. And they do that in the second line setting.
But from my experience, we find some the PD-L1 overexpression but it's lower. It's just 1 or lower 5%. We try use the anti-PD-L1 or PD-1 is not sensitive. But if the patients with the MSI high, it's the response rate is high.
So at this moment, maybe we choose PD-L1 expression, may be a good biomarker. But then the further question is, what is the cutoff? 1%, 5%, or 10%? That's an unsolved question.
It depends on your desire. You want to include more patients, you have to lower the cutoff value. You really want a very nice data, you have to elevate your cutoff value.
Well, the desire has been defined, right? Because it's an ongoing study. Okay, that's already accruing with a PD-L1 of 1%. And in that trial, yeah.
In Pembro study, they use 1%. In lung cancer trial, as you know, with Pembro, they used 50% PS, and in Nivo study first line, they used 5% with a negative result.
So this trial, we're talking about the phase 3 trial, is all comers. And I think Junfang is talking about the new potential new trial. So that's a different. So Dr. Mang is you are the principal investigator in our 007. It's all comer trial, but we're going to look at PD-L1 at different cutoffs retrospectively.
Can I ask a quick question? Which assay of PD-L1 staining do you use?
We use our own assay. It's a little bit different than other companies. So we are developing a companion diagnostic test kit, use a proprietary antibody from Merck, and we are working with Dako developing this test, and we've already been using this test in our non-small cell lung cancer for patient selection and enrollment. But for gastric, it's all comers for the phase 3 trial.
Yeah, okay. Now, may I ask you one more question? So what's the chance of crossover from the control arm there, given the fact that Nivo was coming up with a positive trial, as reported a couple of days ago?
Actually, I like to, finish the enrollment from Japan and United States first, because they're gonna use nivolumab after 6 months or something. But in other countries, still it'll take us some time to get reimbursement. So, not an issue for this kind of trial at this time, I believe.
You're saying that there could be some crossover, but it's not so high, and it's more likely in the West.
With the time, you're right. With the time, there is increasing chance for those patients to get some IU after progression. Yes.
Yeah, and then again, I'm asking these questions because I would like to see a positive outcome in this particular trial. So I'm just testing the weak spots here.
Yeah, I think that definitely it's an important issue, the crossover issues. But it may not be that significant in gastric cancer in my mind, because this is a relatively more aggressive disease. So once patients have the progressions, there might be not enough window for them to go on the next line of therapy. So I think that the impact will be not that significant in my mind.
So I have one more challenging question. So we all have spoken about maintenance, about the maintenance study. if you would now be able to design the study now, would you still do a maintenance study or would you do a treatment starting from the beginning?
Actually, so first I'll talk with the US FDA to have progression-free survival as the primary endpoint, as in RAINFOR study. So nowadays there are so many options for patients. So I think OS is not good. I mean, endpoint for the efficacy of drugs. So it is very, very important. If they accept it, you can do it. Why not? And another thing is, as mentioned already, we're gonna go for highly, responding patient. For example, PD-L1 positive population at this time, not all comers.
I think if you use the outcome patients, maybe you will lose this clinical trial.
Yeah, if we consider the development in the lung cancer, so in the second line, they see some improved survival. So then they'll go ahead to the first line, the single agent. So that's ambitious, right? So that they get so high selection of the PD-L1, 50% of the patient. So maybe go back. Of course, maybe not in this time. Maybe a little bit later. So for the single agent compare with chemo in first line, but we should get more data in the late line efficacy.
And we also think the maintenance is not a good choice for gastric cancer patients.
You don't believe so?
Yes.
I just had a quick question. So what is the percentage in terms of PD-L1 expression? We know we saw from the Keynote versus the Checkmate trials in non-small cell lung cancer second line. How many, the feasibility then of screening and doing it on patients?
In Keynote 12 study in gastric cancer, 40%. 40%.
At what, 1%
Yeah.
cutoff?
1% cutoff.
Yeah, but
But is that going to be
50%
enough?
around.
I guess we'd have to look at the data.
The 50%, how much the ratio? I don't know. I have no idea. No idea. But the expression of PD-L1.
It would be good to take a look at what the different percentages
So
are.
we should go back to look at
different cutoffs and then decide from there what is the feasibility then in terms of accrual versus. I would try to push it as high as you can, but not restricting the numbers.
I would like to go back. Now it's working. To the biomarker question. So we talked about PD-L1 expression. We talked about MSI high. Are there any other markers you could think about we could use maybe for an explorative way to be implemented in our studies, which we then later may have to validate, where we could identify patients better, beside what was already known? Any other ideas?
I think another status is the difference with the China with Korea and Japan, because the patients in China, lots of patients was diagnosis is the late stage, so maybe for this population is a higher the population with the MSI high. Because for the patients when the diagnosis, they have lost the operation. But up to now, we have no any data.
Yeah, okay, so next question is about, let's say nivolumab may approve very soon in third-line setting. So just think we a little bit behind. Then the question is there any other development paths we can explore other than switch maintenance? For example, shall we consider first-line combination with chemo, or even in new or adjuvant setting or others? So it's also a very big question.
I'm interested in the first combination with the chemo. And in the first, one or two chemo cycle, we find that the tumor shrink decrease very fast. So I think there are more new agent will produce. So there will increase the sensitivity to the immunotherapy.
For adjuvant setting, actually, UNO already started their study in adjuvant setting. So Nivo is being tested in adjuvant setting. The study was activated in this year. And another company is, planning to start another study. It is a little different setting. But one study ongoing, another study in planning at this time in neo or adjuvant setting.
So it's really a very crowded setting.
I have ever heard a novel approach is to give one shot of the anti-PD-1 or PD-1 therapies and to look for the changes of biomarkers, say in the blood, because there is now some data emerging showing, say, the reinvigorations of the Treg in the circulation could be a marker predicting the efficacy of immune checkpoint inhibitors. So I think that would be a quite interesting idea to me. If I have the chance, I would like to propose a trial like that.
Yeah, we also do some research, for example, the protein profile. We found that diffuse time patients will divide the three subtype, and the one subtype is sensitive to the immunotherapy.
Just one last point now I remember, just looking at the publication, there are several molecular classified subgroups, just like lung, in gastric. So, like PIK3CA driven ones, and EBV positive ones, I don't know whether you might want to look at it as an exploratory thing.
Okay, so the last question is about combination. And would you consider another combination trials with avelumab with different partners? For example, within Merck, upcoming is IDO inhibitor, and also we have a c-MET, DNA PK, and also interleukin 12. So, and also we have approved drug in maybe not in at least in Japan, ramucirumab, and in China, a partner, and also various investigational drugs. So, what's your opinion? Which one you would have the most interest to combine?
I'm very interested in the DNA PARP inhibitor and TGF-beta trap.
I'm also interested in DNA PK because that agent will increase the DNA damage. That means mutational overload. So potentially, it may be synergistic. And another very interesting compound to me today is LHS-IL-12. Very new, probably not from other companies at this time. So I'm very, very interested in the compound at this time.
Why do you think? Where do you see the specific rationale for the NHS-IL-12 in gastric cancer?
Frankly, I cannot say that it is specific for gastric cancer. But in general, yes, the combination may be synergistic in human tumors. And for others, for example, IDO inhibitor, you are far behind other companies. So
a question to Warren.
Model already, the combination.
Not
Do you-
yet.
No, maybe do some tumor model. Confirm the synergistic effect of the both.
I mean,
That is-
so Reinhard did show, we have very nice synergistic effects, avelumab combining with NHS-ALT, but it was not a gastric specific
Okay.
model.
I see.
But,
So you see
yes.
the synergistic effect.
Oh, yeah,
Correct.
absolutely.
That's
absolutely.
good.
A combination of anti-angiogenic therapy is interesting to me, given the fact that the RAM and apatinib are all approved drugs for these indications.
And I think there were also some first checkpoint inhibitor ramucirumab combination data, which I guess looked very exciting. Is that true?
Yeah.
So, yes, no. Okay. So I think there are quite interesting data also with MEK inhibitors in combination of PD-L1 combined with a MEK inhibitor, especially in colorectal cancer, as it was highlighted at ASCO. Yeah? So a MEK inhibitor plus PD-L1 checkpoint inhibitor. So how do you see this? Also, is this also maybe an opportunity for other indications, and how you see this in general, this combination of MEK plus?
actually, I'm part of that study combining cobimetinib and their avelumab. So actually, we are so surprised by 17% response in KRAS mutant microsatellite stable colorectal cancer. So it is moving forward to phase 3 trials. So the combination seems to very, very interesting, and we can try in other type of tumors also.
Other opinions? Okay. I give it back to you. Yeah.
Before we leave that slide, we commented on adjuvant therapy, and you said it's crowded, others. How about perioperative therapy? You give neoadjuvant, you look at the response, you determine whether you continue